Hello, it's Thursday. It's a special edition of Teach Me Tuesday. As promised, we're having two Teach Me Tuesdays this week since last week I was unable to do one due to my surgery. Today we are going to dive into skincare in the NICU. We're going to kind of do a basic level review of skin maturation and skin breakdown and diaper dermatitis. I do want you to know that on the diaper dermatitis slides, there are some pictures of butts and I had to block them out because of social media, but you can see these on the internet. I will link them in my Instagram stories. The CHOP diaper dermatitis guideline is kind of, I think, what most people these days are basing their own guidelines on with their products. So I'm going to go over that, but I did block out the butts because of the social media. So I just wanted to preface that there will be butts, but they will be blocked out. So let's talk about the development of a premature baby's skin. It's wild because in utero, the skin's not really supposed to be like this fully functioning organ, right? The skin is a major organ, we all know that, and it has protective enzymes, it has protective layers that keep bacteria out and keep fluids in. And in utero, the baby's like swimming in water and their skin's like, oh, doing great here. I'm going to focus on developing my lungs and my heart and my brain. And then we come out early. And the skin has to mature at a faster rate than it anticipated. So we have to figure out how to help them and to overcome those unique challenges that they have. So here's the layer of human skin. I'm sure we've all seen a picture very similar to this over our life, right? We have the epidermis, the dermis, the hypodermis. We have our fat layer, which is great if you want to stay warm, but not great when you're a premature baby because it's just not there. And then the stratum corneum. So all of these things are helping the baby kind of maintain their temperature, their fluid status, their growth, their protection, etc. But for a baby that's born less than 28 weeks, similar to that picture I was on the first slide, their skin is thin and transparent. We all know this. Like, this is why I say it's easiest to start IVs on babies that are that size, because you can just like see their veins. They're like right there shouting out for you. So because of that, they have a high rate of transepidermal water loss, TEWL. We're going to use that word again moving forward. So because of this transepidermal water loss, could we call it T-well? I don't know. It leads to challenges in hydration and thermoregulation, and that's why we use humidity, which we're going to talk about on the next screen. But that humidity is also going to force the stratum corneum to develop faster, which is what we wanted to do so that we can help the baby protect themselves from injury and from temperature loss and to grow and infection, etc. Babies also born less than 28 have very minimal subcutaneous fat, so they can't stay warm. So that's why we have, temperature problems. And then they have less barriers against pathogens. The infant skin prior to even 34 weeks, that outermost layer of the epidermis, the stratum corneum, is underdeveloped. So the skin is less effective at protecting against infections. So we've got a few things going on here. Also, the subcutaneous fat is still not present as much. So we tend to think that our babies born less than 28 weeks, less than 30 weeks, those extremely premature babies, the ELBWs are the highest risk. But even those babies at 34 weeks, their skin is not all the way formed because for some crazy reason that mitochondria has a way to develop the baby in utero. And we're asking it to do it in a different order when the baby is born premature. It's the same thing with the kidneys, with the liver, with the lungs. They're not supposed to be doing any of this work until, 34, 35, whatever, weeks, 40 weeks ideally. And when they're born premature, they have to do the work. And so the body develops in a different order. It's really important to keep that in mind because we think like, 34, 35 weekers are going to just fly. And we all know as NICU nurses that they often don't fly. I maintain that a 34 and 35 weeker is the hardest admission because you never know what they're going to do. Premature baby is pretty, an ELBW, real easy to guess what you're going to do. 35 weeker, they're tricky. So let's talk about humidity. Humidity has played a controversial role, right? Before, we would put these babies in incubators, we'd put the temperature on, thought they would do great. We realized, hey, humidity is going to help prevent the bad effects of T-well, right? Transepidermal water loss. So we need to put humidity in there. That's going to help mature the skin and stabilize our hydration status. So initially we're going to use it anywhere from 70 to 90%. You should have a policy in your unit. We do. It's one I have to refer to all the time just because it has some nuances to it. And I think it's always best to look back at the policy before you make a change. So with that in mind, we start them at 70 to 90, and then maybe the next week we wean. Maybe we wait 2 weeks to wean. I've worked one place where we did 80% for 2 weeks, 50% for 2 weeks, and we turned it off. I worked somewhere that it was 70%, and then it was 40%, and then we turned it off. And now, where I work, we keep it on until, they're 4 weeks old or 31 weeks, something, so that we are letting that, again, like I said, I have to review the policy every time, skin mature in the setting of humidity. It really does play a crucial role. And yes, I think we've all had this situation where we've had like the rain out on the incubator and we're like annoyed. But remember, the baby was in the womb where it was full of water. Humidity can also play a role in fungal infections. So you have to be very mindful of how high you're turning your humidity. And that's why most places kind of stick around that 70%. We turn it higher when we're worried about their sodium levels. And so that is something you have to weigh the pros and cons on. Higher humidity levels, A, you're going to get more rain out, but B, it can increase your risk for fungal infections. So you have to weigh those pros and cons. So that's humidity, that's the premature baby skin, that's the development. What are some things that we do to kind of help protect the skin? So often we will use a skin prep. So that's to protect the skin with that delicate and developing nature of the infant's skin. It's going to help protect the skin integrity, prevent damage, reduce infection, and help attach it so we're not like attaching, reattaching, attaching, reattaching, attaching, reattaching, and then we get risk of breakdown. And then we have the adhesive removal. So when it's time to take the adhesives off, we can use this for electrodes, IV lines, feeding tubes, wound dressings, so that we can kind of minimize that skin trauma to prevent skin tears, blisters, and abrasions. So first we have this thing like humidity that's helping get the baby's skin prepped and get the baby's skin growing in a way that we need it to, maturing. And then we come in and we're like, hey, let's see what we can do to help protect the baby. Now, it's not always successful. Our babies have extrinsic and intrinsic factors that really play a part in the development of the skin. And sometimes we still get skin injuries. So we're going to look at a few. There's some pictures on the next slide just to warn you. So general health, right? If your baby is not doing well, they already have an infection, their nutritional status isn't great, they're not growing, they're really young, they've had a pressure before, that's going to affect their breakdown. And also friction, pressure, shearing, all of that. We've had injuries, so these are all pictures. They're cited there of where they came from. I found them on the internet, but they are from having premature skin. Maybe we left them in a position too long. There have been situations out in the literature where babies were left on a medical device, like a cap from a feeding tube, a cap from a medication. That's going to really make that indentation and hurt the baby's skin. We've seen, nasal cannula breakdown. We've had breakdown from when the tape came off of an ET tube. Every NICU is trying to keep their babies intubated less, right? We want to get the tube out. We all know days off the ventilator equals lung growth. So we're using things like Fisher-Paykel, RAM cannulas. Those push on that tiny baby's little skin. So having guidelines in place to say like, hey, this is what we're using. This is when we're going to change it. This is what this baby needs if you're this age, etc. And then, of course, we could have a PIV infiltrate. So you probably have all seen one. I remember my first one. I will never forget it. You feel terrible. They can happen like that. You're doing your hourly checks. You come in, and the next hour, it is out. It is so scary, and you feel horrible. But making sure you're doing those hourly checks, that they're in a safe place, that you have a good skincare guideline to help you with them, that we're not putting too many harsh medications through there. If the baby is on prolonged antibiotics or needs to be on a high level of dextrose, that we're getting a central line so we're not harming the vein. and then treating them according to your policy, whether you are giving medications, elevation involving plastics, etc., using your PIV infiltration guidelines or policy. So diaper dermatitis is our other main form of skin breakdown in the NICU. The number one thing I want you to take away from here is down in the red, and so I'm going to go over it like 3 times. Diaper dermatitis is caused by many things. The NICU, the babies are at high risk, right? Their urine is often acidic, so that's going to break down their skin. We are feeding them things that maybe their guts weren't prepared for, etc. Also, any babies on antibiotics that are in withdrawal, having loose or watery stools for whatever reason that might be, or have short gut syndrome, they are at higher risk for having issues with diaper dermatitis. So creating an algorithm, knowing what to use, my pet peeve is when I come into a room and I go to change a baby's diaper, and you like open up, the drawer of the crib or the incubator, and there's like 5 diaper creams and 5 different wipes, and everybody's doing it differently, and they're opening the baby's butt to air, and we're putting stoma powder on, like all these weird things, and I'm like, whoa. So having a guideline to kind of say like, hey, this is the order we're going to do things in. So number 1 is prevention. And so that is having a basic barrier cream that goes on with every single diaper change and protects. It's just a layer of protection. It's like you take the skin and you put another layer on top of it, so that when the baby pees, it's just going to that instead of on. So that's doing it every single diaper change. If the skin becomes red, but it's still intact, you would want to use a cream with zinc in it, such as Desitin, Criticade Paste, or any of those creams out there. I know that there are so many things out there that you can use. So it's knowing what your facility kind of has on par, what they typically use. That's what you would want to put in your algorithm. If the skin becomes open or excoriated, you want to level up to something such as triple paste, triad, Boudreaux's butt paste. I have seen in a few things. I saw that in Cincinnati Children's Policy. You can find all of these great resources out there on the old internet, and they really can help you develop your guidelines. But the most important thing is that you want to layer this on thick. They call it cake icing. And if someone who loves icing on their cake, I can understand having to put a lot on there. When it's the baby poops, the goal is that you are dabbing the poop off of the cream, not wiping the cream off, because then you're wiping all those layers off, and you're going to probably wipe off the layer that the baby has formed to themselves. So do not wipe the cream off. You want to layer it on thick so that we can dab the stool off. The thought is if you have put enough of this barrier cream on, the stool is not touching the skin. It's touching the cream. That is going to help your butts heal so much faster than anything else you've done. So put it on thick and dab it off. It's in red. I'm going to show you CHOPS, Children's Hospital of Philadelphia's algorithm that many people base theirs off of. It's quoted a lot in the literature. I have covered up the butts like I mentioned, so just know that they are covered up. And if you want to go and see this, Google CHOPS diaper dermatitis algorithm, and it will show you what their butts look like. So creating this easy to use algorithm is what we at my current facility kind of based our new algorithm on. This one is from CHOP, and I've edited the photos for social media, but it is saying like, hey, we starting with prevention right over here, right? So they're using petroleum, apply a thick layer over the area. Think icing on a cake, right? It's right there. And then we have intact skin, but it's at high risk, may have erythema. So they're saying we could get to a zinc barrier cream here. Then we have intact skin, but erythema, a zinc barrier. So what I like about this is that it's in plain language, it has pictures, it's saying what to do. What is not as helpful, which I will show you on the next slide, again, there's going to be some butts here, is what we are using at my current facility, and I've covered the butts, but the goal of this is we have then put our product names of what we use into the algorithm so that the nurses know, like, this is the specific thing I grab. Using something like CHOP as your basis is great, but then it's just saying like, oh, use a petroleum, and you're like, okay, well, which one is that? Is that Alkafor? Is that plain Desitin, etc.? Getting your products names in there is going to be helpful. So that's what we did, is we used CHOPS as our basis. Our team worked on this and said, like, hey, we're going to use these products to move us forward. So again, the images have been altered for this, but what you can do is take the evidence and use it to make it specific to your facility. What we want to tell our parents is that, like everything, good skincare begins with hand hygiene. So we want to decrease the bioburden. We don't want to introduce any sort of infectious diseases into the skin that does not have its barriers in place. We also want to get our babies out skin to skin. They can get their healthy microbiome going by being on their parents' skin. We want to make sure our parents are scrubbing their hands, using hand sanitizer, helping with diaper changes, careful handling of the baby's skin. All of us, when we are checking our beds after a diaper change or during a care time, making sure we did not leave any caps in the bed. And then, of course, encouraging our parents to let us know if they notice any changes in the baby's skin condition. So skincare in the NICU is complex. There's just like no way around it. So many of the items that we're using, whether that's ET tube tape, the Fisher-Paykel, the Ram cannula, the OptiFlex, whatever it is, we need that to provide safe care and to help our babies do well. But it also can harm our babies if we are not watching what's underneath it, if we're not paying attention to and checking all of our areas, right? Pulling down and looking at your area around a CPAP mask, whatever it might be. Having guidelines in place. So for Fisher-Paykel, having guidelines in place. For diaper dermatitis, for a PIV, making sure we're checking it every hour, knowing what to do if something happens. When in doubt, take it out and get treatment going to it. Medical device, skin prep, all that. So together with the families, we really can prevent breakdown and help the skin mature as safe and in a safe and comprehensive manner. So thank you for joining me on this special Thursday edition of Teach Me Tuesday. I hope you have a great day, and I will see you next Tuesday for another fun Teach Me Tuesday.